use my personal computer now and I don't have a camera, if that's okay.
That's totally fine. I think since you're screen sharing, it'll be fine.
Okay, perfect.
Okay, so I think we're live now. And it looks like we have about 30 people who have joined us since we went live. So welcome for those of you coming back from lunch.
Okay. Should I go ahead and get started then?
Um,
Or wait a few minutes?
let's give it maybe another 30 seconds. And then I was going to go ahead and give you a brief introduction, and then we'll roll right into your presentation.
Sure. Can I begin sharing my screen now, or do I have to wait until you finish talking?
Sure, go ahead and get it set up if you'd like.
Sure.
Okay, so thank you everyone for joining us for this breakout session. I hope you guys all enjoyed your lunch. It is my great pleasure to introduce Lindsey Westerhof, who is a board-certified ambulatory care pharmacist at Mercy Health St. Mary's in Grand Rapids, Michigan. She practices within outpatient family medicine and has a strong interest in public health research and advocacy. Her involvement with antimicrobial stewardship initiatives began in 2017 with support from her colleague Lisa Dumkow. Her role also includes precepting PGY1, pharmacy residence, and patient care and longitudinal research. So thank you, Lindsey, for joining us today and sharing more about your research in antimicrobial stewardship. Feel free to begin your presentation.
All right. Thank you so much for that introduction. Again, my name is Lindsey Westerhof, and I'll be talking today about the history of how we've been developing our outpatient antimicrobial stewardship program at my small community hospital. And so, all of our programs thus far have been led by pharmacists. So I'll be kind of speaking a bit to, my experience of how I've gotten involved, but I'm happy to try to answer some questions at the end as well for anybody that may be interested in doing a similar thing or adopting certain aspects to fit your institution. So as I was already introduced, I do work in an ambulatory care setting. So I practice in 2 family medicine clinics. In my role, I primarily do chronic disease management and comprehensive medication reviews. And so infectious disease is actually an area that I have not had very much training in, nothing formal. It's all been kind of on the job, informal training that I have learned through my colleague, Lisa, who is our inpatient infectious disease board certified pharmacist. So I've really looked to her to kind of help co-develop a lot of our programs. And then she has let us kind of take the reins from the ambulatory pharmacy perspective in our offices to really implement some of our programs so far. So I don't have any financial relationships, disclosures, or conflicts of interest. And by the end of this presentation, the goal is that you will be able to identify methods of stewardship implementation that are feasible for a given outpatient clinic, list the benefits and limitations of non-ID trained clinical pharmacists performing stewardship activities, and perform a SWOT analysis for your own institution, including development, implementation, or optimization of an outpatient antimicrobial stewardship program. So a little background on why we care about this and doing outpatient antimicrobial stewardship. Well, we've got 2 good reasons, one of which is that it affects a lot of patients, and 2, that it's required. So to delve in a little bit more on that, we know that greater than 60% of antibiotics prescribed are in the outpatient setting, and at least 20% of those are by family medicine providers specifically. We also know that antibiotics are often prescribed inappropriately. So that might be, was a drug needed to begin with, or if it was, is the correct antibiotic chosen? And so we're able to, was there a question?
Lindsey, I think that the Microsoft PowerPoint screen share is not advancing. I'm still seeing your introductory slide. One recommendation that we've been giving presenters is maybe to share your entire screen versus sharing the PowerPoint application. It seems that there is a significant lag when you share specifically PowerPoint.
Okay.
There we go.
Just how is it looking? Okay. Can I open
Yes,
it
much
up?
better.
Can I open it up here like it is a
Oh, I think so.
presentation?
I
Okay,
think
let me
so.
know.
Yeah,
Okay.
that looks good. Thank
Is
you.
it advancing now? Okay. All right.
And
So
then
sorry about that.
there is a little
Yeah,
if you want to hide that. Perfect. Thank you.
perfect.
Sorry about that.
Yeah, you're welcome. All right. So yeah, so we know that there are a lot of antibiotic prescriptions that are inappropriate for various reasons. And so therefore, this is an important setting to have these antimicrobial stewardship activities. And then secondly, it is required by the Joint Commission as of January 2020. And this is specifically regarding concerns about antimicrobial resistance as well as adverse events. There are 5 elements of performance that we can measure ourselves against to help get these programs started or to optimize them. So the first of which is identifying an ASP leader. So that could be whether it's a physician champion, some other kind of leader within your organization. It could be a pharmacist, somebody that's going to have that clinical expertise that can help really take ownership of the program to make sure that we are implementing and measuring our changes over time. Establishing annual goals. So that could be a goal related to a specific syndrome or condition, such as UTIs, or it can also be goals related to a specific antibiotic class. So maybe that's going to be targeting fluoroquinolone usage. Thirdly, implementing evidence-based guidelines. So this is taking into consideration national guidelines as well as your more local institutional guidelines and antibiograms. And then fourthly, providing staff with education and resources. So I'll share a little bit about what we've done so far to help educate our prescribers and resources that we provided to them to help make them more successful. And then lastly, collecting, analyze, and reporting that data. So in order for us to know if we're making a difference, we want to have some baseline data to compare to over time to see if we are making improvements. And of course, sharing that data, publishing it, so that way others can learn from us. So a little bit about the history of antimicrobial stewardship at my institution. It all started here actually in the inpatient setting. So Mercy Health St. Mary's Hospital, which is a 350-bed community teaching hospital. We do have a full-time PGY2 trained ID pharmacist dedicated to antimicrobial stewardship, as well as an ID physician that has 0.1 of his FTE time dedicated to stewardship. And this is where all of our ASP has begun. And with the development of our program going to outpatient, our inpatient team is the one kind of supporting and leading outpatient and giving us the tools on the outpatient side to be the most successful. So the outpatient setting that we have here is our Mercy Health Physician Partners, which is a physician organization. We have 22 primary care offices located throughout West Michigan. Currently, we have 4 ambulatory care pharmacists that are embedded into primary care clinics. Myself, I am actually a subcommittee member for the Antimicrobial Stewardship Committee through P&T. So I'm kind of that outpatient pharmacy representative, being involved with projects, education, regarding some of the goals that our institution has set. And so most of us have not had any formal ID training. One of them did do a certificate program through MedID, and one of the current ambulatory pharmacists is also a faculty member with the local college of pharmacy. And so not all of us are currently performing antibiotic stewardship activities, but we are a pretty small team hoping to expand, but we're already trying to really dig our feet into outpatient stewardship, even if we're small. So this is kind of the history of our services. So 2013 is actually when our institution first even had its own ID pharmacist working on antimicrobial stewardship solely. So it's a relatively new program starting in 2013. So it was primarily inpatient focused. That did start to expand to some of our outpatient settings with emergency department, later on that same year, where they did most of their interventions were via audit and feedback, as well as discharge culture follow-up, where the pharmacist could assist with prescribing the appropriate antibiotic under a collaborative practice agreement. And that was used for UTIs, STIs, and skin and soft tissue infections. And then in 2015, our program expanded to urgent care settings, still using a collaborative practice agreement where the pharmacist is actually able to have that delegated authority to prescribe those antibiotics to assist with the other prescribers. And that was focused on UTI, STIs, skin and soft tissue, and upper respiratory. And then 2017 is when we expanded activities into outpatient primary care offices. So that started out with doing audit and feedback, so from a retrospective standpoint, versus kind of in the moment prospective using a collaborative practice. So pulling data to see how things have been going and giving feedback to those providers. And that was initially focused on UTIs and upper respiratory infections. And then we expanded that to include skin and soft tissue infections in 2018, and also looked at some additional offices. And then in 2019, we actually started to experiment a little bit with doing more selective audit and feedback, meaning that we actually only did an audit and gave feedback on half of the antibiotics prescribed, just because we were finding that it is quite time consuming for somebody to be doing audit and feedback on every single antibiotic for those top conditions that we prescribe for. And then our most recent project, just in 2020, has looked at ways that we have optimized tools within our electronic health record using antibiotic order sentences, specifically for UTI and skin and soft tissue infections. So this is a little overview of our process that we've used each time we're looking to develop a new goal and start measuring our progress. So pulling a data report from our electronic health record, we do use Epic at our institution. So we can look at specific dates, maybe gather some baseline data from a 6-month period, for example. Looking at that specified syndrome or a specified antibiotic that we want to target, developing goals based on what the need is. So performing that needs assessment. And then determining that baseline prescribing, you can look at things like demographics, such as, how often are we using this antibiotic class versus another one? Again, fluoroquinolones tend to be a big one that a lot of people will try to target at first. So looking to see, how often are those being prescribed? And then comparing the current prescribing trends to our guidelines. So that's going to be our institutional guidelines that we've created, that our ID pharmacist and physician have created and continue to update annually, as well as with that antibiogram, taking into consideration those local resistance trends. So then we come to performing our intervention. So far, the different types that we've done is education, audit and feedback, using a collaborative practice agreement, as well as interventions in the EHR. And then doing a similar measurement of demographics in guideline concordance afterwards, so you can compare that pre and post for your data. And that's just a great way to, share that information with our providers, so that way they can feel empowered and know that things are changing, but also, for publication's sake and sharing that with the rest of the community. And then each time that we go through one step of our plan, we continue to create new goals. So looking to see what worked, what didn't work, learning those lessons, and then making adjustments and trying to see, how can we still perform, excellent interventions, but doing it maybe more efficiently, being that sometimes resources can be quite limited. So now I'm going to delve in a little bit more specifically into some of the interventions that we've been doing in the outpatient setting. So I mentioned before provider education. So what we have done is usually kind of a meet and greet session.
Lindsey, I think we lost you there for a second, both the screen share and the audio. And you're still on mute if you are speaking. There we go.
Okay, I'm so sorry. I only just heard that about the part about being muted, so I'm so sorry. Can you hear me now?
Mm-hmm.
Okay, perfect. So I probably don't have time to go back necessarily, but hopefully you could see my slides. But I was just talking about with provider education, having everyone on your team. So whether that is the pharmacists that are embedded in your office, as well as any of the physician champions or the ID physician from the inpatient setting that may have some pre-existing relationships with those prescribers. So reviewing them, reviewing, the goal of the initiative, reviewing the outpatient empiric therapy guidelines and antibiograms, and doing that all face-to-face if possible, just so that way they feel a bit more comfortable with what's going on, have a chance to ask questions. And I do recommend, trying to start out by, when you're doing that needs assessment, is figuring out, well, what are the most commonly prescribed antibiotics or most common indications, and focusing a bit on that and showing those providers, what the data is, and where there's going to be some room for improvement. So what we've often done is create pocket cards for our providers. So the one on the right here is an example of that, and it's printed off in like a 4x6 kind of size. And that's just one page of it, but we'll have several pages of this that a provider can then either, stick it in their pocket if they want to, or pin it to a corkboard near their desk for easy reference. And this just has a quick summary of what our empiric therapy guidelines are for certain conditions. And then our antibiogram as well, we did share during a lot of our initial education. That's updated annually by our inpatient stewardship team. And then audit and feedback has been the bulk of the interventions that we've been doing so far in our outpatient stewardship projects. So this is a type of intervention that can be done in a couple of different ways, and we've explored several of those options. First of which is written or verbal. So written can be done via a paper, where we've had pharmacists that will, write out, kind of their evaluation of an antibiotic. Was it prescribed correctly? Did they do a good job? Where's there room for improvement, and how so? And that can be done, either paper that is handed to a provider, put into their mailbox, or my preference is actually electronic, where I am able to type it into some kind of platform, either that's built into our EHR or through email, where then that information is sent back to the provider that way. Also, sometimes they've done it verbally, so face-to-face, being able to go up to provider, asking them if they have a few minutes available to go over some feedback that they have. There's also options for auditing every single prescription in a specified time frame, or being selective. So again, that was a thing that came up for us, which was that auditing every prescription was quite time consuming. And we thought, well, maybe we can still have some benefit, even with doing a 50% reduction in how many we are auditing and giving feedback on. And then the frequency that we've been doing so far is either a half a day once a week, or doing a full day every other week, and trying to give feedback at those intervals. So that way it's still fresh. We can still continue to make improvements over time, instead of doing it only once a month, for example. So a couple of things that we take into consideration during our audit is in the chart review, kind of answering these questions and then keeping track of that in an Excel spreadsheet. So looking to see, for this antibiotic that was prescribed, was it even needed? So for example, if it's something like an asymptomatic bacteremia or bacteria that is, not in a pregnant woman, for example, we would say, no, the antibiotic was probably not needed. So we would do that for the given indication. And then looking to see, was it the best drug or the best agent chosen for that indication? So we're comparing that to our institutional guidelines, in which we have several medication options listed, and we have them listed in the order in which we prefer them to be used. And so we're looking to see, was that one chosen, or was there like a third option chosen that was really not preferred and maybe only reserved in the instance of a medication allergy or a prior culture and sensitivity that showed that that one didn't work. And then also we'll look at, what it was the dosage and the frequency. So how many milligrams and how many times per day was that prescribed for? Was that the best dosing regimen? Duration of therapy. So how many days was it prescribed for? And then considering, was the entire regimen considered appropriate? And so that was only given a yes if every other component listed above is also considered yes. So that was kind of our composite endpoint that we use for our audit. And then other considerations, for helping us to determine if these are correct answers for us are looking at, medication history. Do they have allergies? Recent antibiotic usage? What worked? What didn't work? Prior cultures and sensitivities, patient age and sex. So, thinking about, are they pediatric? Are they adult? Male, female can make a difference as well. Pregnancy status. So we kind of just go through the chart, very, in a critiquing eye, go through and look to see one by one, are each of these appropriate? And then for the feedback, these are some examples of that written feedback. So a couple templates that are here that our pharmacists have used in writing a little letter, basically, to a provider, saying, with this patient scenario, they were seen on this date, prescribed this drug for this indication. And in the future, we would recommend considering the alternative of blank, and you can fill that out. And so we would actually give feedback on both things that went well, saying, great job, keep up the great work with this area. And then alternatively, for anything that needs some tweaks in the future, we would just give recommendations for considerations in the future. And then here's an example of one that I had given to one of our family medicine residents. And so basically kind of plugging this information into a template that I had pre-built, but letting them know, this is your biweekly feedback report. Great job prescribing appropriate antibiotic therapy for otitis media. And I also include the patient's MRN directly in there. So that way, if the provider was wondering, I don't know if I remember this case, or I want to clarify what I did or what my note said, they can easily just copy and paste that MRN and go into Epic to look up that case. So I would say, great job doing prescribing for this, by using watch and wait prior to prescribing the antibiotic. So in that case, they eventually did prescribe it, but they didn't do it right away. Regarding UTI and pregnancy, reminding them that nitrofurantoin was still our first line treatment for UTI in early pregnancy. They actually had used cephalexin instead. But we do kind of consider, okay, well, if you're using this drug, was at least your dosing and your duration of therapy correct? And so we would give feedback based on that as well. So for this person, they used a drug that we didn't prefer. However, they also did not end up using the frequency we preferred. So sometimes this medication is prescribed 4 times a day. We really would prefer twice a day, just for sake of compliance or adherence to the medication regimen. So this is kind of an example here of how we would give that feedback. So really trying to be supportive, be encouraging, not make people feel, embarrassed or anything like that, like they're really doing something wrong, but just looking to see improvements over time. And then I mentioned that a couple of our settings, the ED and urgent care, do currently use collaborative practice agreements to assist providers with prescribing appropriate medications. So you can see here an example of what that protocol looks like. Specifically, this is an example for uncomplicated UTIs. So this is not something that we currently have as part of like our ambulatory clinical pharmacist group in the primary care offices, but may potentially be involved in the future. I'm not quite sure. We haven't really spoken about that part yet. But our most recent project that we've been working on is using the electronic health record to build order sentences. So when the prescriber is entering in a diagnosis, let's say for UTI, they can click on order preferences, scroll down to the condition for UTI treatment uncomplicated. And then these are the examples of what we actually have all pre-built right into the program. So the provider just needs to scroll down and select the correct one. Now, these are listed in order of preference. So that would mean that we would prefer nitrofurantoin, followed by Keflex, Bactrim, and Cipro. So those are just examples of how we have that built right in there. We did do provider training to help make sure that the providers knew how to get these loaded into their own account. This is a sentence or a set of orders that is owned by one of our ambulatory care pharmacists. And so we have to make sure they can go in and copy that from that user that is maintaining those order sets. And then make sure they can get that in, answer questions that they have. And basically we did that. We gave them some time to play around with that for a couple of weeks before we started, measuring to see how, the usage was. So with some of our audit and feedback, I'd mentioned we did a couple of different ways of doing that. So our initial pilot study that we did at our health system was within one office. It was a retrospective pilot with written, handwritten on paper feedback. But there was quite a lot of significant improvement seen over time. So the study for the audit and feedback period went for 7 months. And as you can see here, that fluoroquinolone usage went from over 80% of the antibiotics prescribed for UTI down to be just about 10%. So that was, they were really trying to target fluoroquinolone usage kind of specifically with this pilot. But they did also look at within UTI and upper respiratory infections overall, which ones were guideline concordant antibiotic selection. So still comparing that to our outpatient guidelines for empiric therapy and looking to see how compliant were they with following those. So we were very happy to see that in this pilot, we were already seeing some significant changes from our providers. And then the next project that we did expanded that audit and feedback to cover skin and soft tissue infections. And this was a project that was done in our family medicine residency clinic. And so we did find significant improvements across all three disease states in total, from 38.9% to 57.9%. And this method of feedback was written but given electronically and sent to the patients via secure chat attached to the electronic health record. And so we were able to find that there were significant changes overall, but also for those individual components of that composite. We did find significant changes in drug choice, the dosage, the duration of therapy. However, with that previous project, that was auditing and giving feedback on every single antibiotic for those three indications. And so our next project was looking to see, well, how can we scale that back with our limited resources and time? So the next project was selective audit and feedback. And this was also a retrospective quasi-experimental study. And that one did show significant improvements in total guideline concordant prescribing from 27.5% to 50%. And that was for UTI and skin and soft tissue. These pharmacists did a combination of feedback styles, which was first trying to do a verbal face-to-face feedback with the prescriber. And then if that wasn't an option based on availability, then they would give that written feedback into a provider's mailbox in the office. And so they were able to see not only that total prescribing, but specifically within that, the appropriate drug, duration, and therapy indicated were all statistically significant. And then lastly, our most recent project we did was implementing that electronic health record order sets. And so we did find that by implementing that, we had total improvement in prescribing from baseline of 24.5% to 39.7%. That was specifically just looking at UTI and skin and soft tissue infections. So we were very excited to see that not only was it significant for both of them combined, but also for UTI and skin and soft tissue infections individually. And so, like I said, our process is that we're always thinking about lessons learned, what are things we want to consider, what do we want to make improvements or changes on for the future. And so some of the tricky parts of this are that, we know that implementing antibiotic stewardship in the outpatient is very important. We have some guidance, some recommendations for how to do that, but it's not super clear. And so we're experimenting. We're seeing what works for us and trying to learn from other people as well. So that's kind of a barrier because it's not quite proven yet the way that some of our inpatient processes have worked. And then we also have some limited resources. So at our institution, at least, we have a very small ambulatory pharmacist group. There's only 4 of us that are there, but we actually have 22 offices. So that means the majority of our primary care offices do not have an embedded pharmacist with that existing relationship. And the majority of us also do not have any formal ID training, just something that's on the job. So that can be, if there are a little bit more tricky questions or scenarios that we run into, we may need to consult with our ID pharmacist who works inpatient and kind of borrow a little bit of her time to help us. But we are very thankful for her for that, and for all of the informal on the job training that she has helped us with. And so, thinking about future directions as well is, how can we do more with little time? This is the golden question there. So depending on your method of feedback, some things can be more time consuming than others. So a lot of I know I kind of mentioned some barriers there, but there are a lot of benefits as well to having an ambulatory pharmacist leading those outpatient activities. And one of which is that the ambulatory care pharmacists that are embedded in the office have existing relationships with the prescribers. They're already working with them on some chronic disease management and looking to them to answer questions related to drug information. So, they're already that reliable medication expert and have that trusting relationship, and they're kind of readily available. So we think that expanding, the presence of an ambulatory care pharmacist to cover more offices will probably be quite useful. And compared to some of our other providers, such as nurse practitioners, PAs, physicians that are also in our offices, the ambulatory care pharmacists just tend to have a little bit more flexibility in their schedule and have the options of working on some of these quality related measures. So some of our future directions are to expand coverage to more offices, as I mentioned, looking to see, how can we do that without a pharmacist being there? So doing more remote or electronic coverage, possibly expanding to more diagnoses. So far at our institution, we've only done outpatient stewardship interventions for UTI, skin and soft tissue, and upper respiratory infections. We also want to definitely explore more options with using the electronic health record because we feel like that can be a method that should be pretty foolproof, if providers are actually using it. However, at this time, we have not yet found a way to know, are the prescribers using the order sentences, or are they still just going and entering in their orders manually? So we don't have a way to know that for sure. So we're not really able to, do that comparison of, just knowing if they're actually using it or not. So we've made a difference in some way. We just don't know how much. And then also asking for whoever that leader is or the person implementing these stewardship activities, making sure that they do have some protected and dedicated time to doing this, because it is time consuming to develop education materials, actually meet with providers, spending time collecting the data, analyzing the data, sharing it. And then we also want to figure out how we can better utilize pharmacy students and pharmacy residents in some of these projects as well. So I think we might have a couple of minutes available, maybe about another 10 minutes before questions. So what I'd like to do is actually make a plan, and everyone that's listening can take about 5 minutes and perform your own little SWOT analysis for your institution. So thinking about what are the strengths, weaknesses, opportunities, and threats. And this could be for any stage. So this is whether you're at an institution where there is no outpatient antibiotic stewardship program, or maybe it has just started, but you want to think about how you can optimize it and make some changes. So maybe do a little reflection on all of that. And then what we'll do is also have the opportunity to share. So thinking about what's a specific SMART goal that you'd be willing to share. So being specific, measurable, achievable, relevant, and time-bound. And so it's a good idea to also write down these goals so that way you can revisit them later. And also thinking more about those specifics of like, who's going to be involved in leading this? What kind of measurement do we want to try to set? And then ultimately, who's going to be the person responsible or accountable as well. So what I'd like you to do is go ahead and take about 5 minutes just to reflect on your own, and then we can regather and you can share in the chat what are some specific SMART goals that you may have for outpatient stewardship at your institution. And we can get an idea of, what's been working well for people and to gauge where everyone is at with that process. So in about 5 minutes, we'll come back together, but go ahead and start throwing in your SMART goals into the chat.
Lindsey, do you think maybe you would be able to leave up the slide with the SWOT goals on it, or rather the prompts for it, and then when we get comments, I can read them off or something like that, just so maybe these people can think about these prompts.
Yes, absolutely. Yeah, so this would be developing a goal for either development, implementation, or optimization of an outpatient stewardship program. So here's some, ideas, I guess, are prompts here for you. So sorry about that.
Okay, I'm not seeing any new comments. However, there are over 70 people who are part of this session. So if anyone wants to take a crack at it, I'm sure we'd appreciate some interactive participation from the crowd.
Yeah, and this could be, the SWOT analysis is kind of an idea for you to internalize where you are to help develop that SMART goal. But if you don't think you're quite ready to, share what that specific goal might be, you're welcome to also just share one of these individual components. What do you feel like is a strength, weakness, opportunity, or threat at your institution that you might be willing to share? So any part of it is welcome. And for those wanting to develop a SMART goal, I'll move on to the next slide here as well, just to review what would be included in that.
Oh, I have some.
Okay.
Okay. They're more so comments and questions rather than a plan. So
Okay.
maybe we can hold those for the end, if that's all right.
Yeah.
And in the interest of time, I'm not sure that we're getting any more
Yeah.
submissions for plans, but if you have any other points to bring up before we open for QA.
Sure. Yep. We'll move along here. So, kind of get to my summary slide now too, because I didn't have a whole lot after this. Are you able to see my slide still?
Yes, actually, one did just come in right in the nick of time.
Oh, okay.
Yeah, so somebody said a strength is their organization is very engaged in things like measures and always is looking to improve by showing the data, and it encourages the engagement. An opportunity would be for collaborative efforts with the pharmacy. They've collaborated on other projects, but they like the idea of collaborating specifically on antimicrobial efforts. And then the threat would just be time.
Mm-hmm. Yeah, thank you so much for sharing. It sounds like your institution is very open and there's a lot of, existing interest that's there. So I'd say definitely try to lean into that and, just continue talking to individuals and key stakeholders at your institution to, get them to be on board with creating some interventions and measuring that. So yeah, keep up the great work. But yeah, definitely time does tend to be one of the biggest barriers. So thinking about how can we do things that are going to be efficient and also leaning into any learners that you have available at your sites too. So if there's any healthcare students, residents, interns, things like that can help with some of that data collection.
Mm-hmm. And somebody else commented that they're really interested in expanding to the outpatient realm, and that it could be an opportunity for them to explore over the next year, but they don't have anything more specific than that as a general goal.
Mm-hmm. Yeah. Well, it's definitely good to start thinking about that. I do feel like it does take at least a year to really start delving into the literature to see, what's been working for other people and to see what's going to be realistic for your institution. So I definitely encourage you to do it and feel free, to reach out to myself if you have any questions. All right. Were there any other pieces that people shared regarding some goals or
no more goals. We have 2 questions for the end.
All right, sounds good. So I'll just wrap up here with some main takeaway points, which are that outpatient antimicrobial stewardship programs are vital for ongoing accreditation of our programs, in addition to it being a good, patient care service to offer. And then it does take an entire team to build a successful program. So you want to think about who are those key players going to be? What kind of providers or healthcare professionals are going to be on there? So that's going to be based on their skill, as well as their interest, their availability, and what kind of platform they have. So trying to find somebody that is a leader in some way through their department is going to help them be better heard and for your initiatives to be taken seriously. And then thirdly, get creative with your interventions when your resources are limited. So thinking about ways that you might be able to do things remotely, electronically, and share how those go for you, if they work, if they don't work, and any ideas that you have. And then also the importance of developing initial and ongoing SMART goals through a SWOT analysis. And so just continuing to do that over time until we are, meeting some of our benchmarks that you may set for yourself. So, all right. Well, that's all the presentation slides that I have here, and I'd be happy to take any remaining questions.
Sure. Our first question comes from Mark Gregg, who is the program director for ambulatory pharmacy at Northwestern Medicine. And he asks, do you have any collaborative practice agreements with your providers?
Yeah. So specifically in the outpatient family medicine clinic, we don't have antimicrobial stewardship related prescribing on our CPA. Our CPA can be expanded to include, any general primary care disease states. I would say that our current role within our CPA is more if a provider were to consult us and ask for our recommendations. So they may say, hey, this is what's going on. This is the symptoms. This was their culture. Can you give the recommendation of what to treat? So that's kind of more prospective. We're not really currently measuring that at the moment. We don't have a CPA yet in terms of like a culture follow-up though. So that we do have that culture follow-up program and then a protocol for prescribing by our pharmacist in the ED and the urgent care. But that may be something that we'll look into depending on time. At the moment, our ambulatory care pharmacists primarily focus on a lot of chronic disease management and trying to achieve some of those quality outcomes. So we'll have to see over time if we may be able to free up some more time with this.
Great, thank you. Next question is from Rashmi Chugh, medical officer at DuPage County Health Department, and she asks, any suggestions for which specialties to prioritize, for example, primary care versus ENT or general surgery, etc.? Thank you.
Yeah, so to make sure I understand the question, it kind of cut out for a second, but I'm just wanting to see if there were any recommendations when choosing if the interventions are going to be in primary care versus specialty. Is that correct?
I think so. That's what I'm understanding.
Okay. Yeah, so I think that's definitely great to consider. I would say there's, going to be a couple things to consider. One is, who's going to be the person that can be the lead on implementing interventions, and then is that going to be part of their jurisdiction, part of their department? Do they have a time for that? And then also looking to see, where are things not going well? So trying to sample some baseline data from various areas might be helpful. So maybe randomly sampling 20 to 50 patients from some primary care clinics, from various specialty clinics, and spend a little bit of time there to see, well, how guideline concordant are they at the moment? So maybe in primary care, they're currently at, 50% of the regimens seem to be appropriate. And then in certain specialty offices, if it's a lot lower, then I would say maybe those would be a good place to start out and to use those resources. So going to where we're kind of bleeding is what I would personally recommend. There may also be some other ideas out there too, but that's what I think would probably be a good place to start.
Wonderful. And Rashmi did follow up and our interpretation was correct.
Okay.
She also submitted another question asking, have you come across collaborative or crossover prescribing stewardship initiatives, such as for opioids and antimicrobials?
So I personally don't have experience with any kind of crossover with that. Is this something that you were thinking about for the exact same patient, or you just mean like crossover in terms of like a similar process that could be used for antibiotics versus opioids? because I do think there would be a lot of implications, this very similar process to what I've been working on, and just swap it out for, does your institution or nationally have a guideline that you want to be following? You could do a very, very similar process, but just swap it out for opioids instead of antibiotics. If that answers the question. I don't personally have experience with that, but I do know that opioid stewardship programs are also becoming a bigger thing.
Mm-hmm. Those were the handful of questions we had queued up. As a reminder for any attendees, if you have any additional questions, feel free to submit them. Rashmi clarified for the crossover if there was any potential leverage for provider education, is I think more so the viewpoint she was taking on that question.
Yeah, I do think that it's definitely, a possibility, and would be something that I would definitely encourage for you to pursue, because I think that is something that is very, very important. And that's, my mind is already starting to go with thinking about, what can I have my future, pharmacy residents work on for some of their projects in the future. So I definitely feel like that would be very applicable and feasible to be doing that. We're starting out with provider education, possibly doing audit and feedback in relation to, goals that we might try to set for prescribing. So thank you.
Wonderful. Well, that is all that we have in regard to questions, unless there are any last minute questions that people want to submit. But otherwise, Lindsey, do you have any contact information you'd like to share if people want to follow up with you after this presentation?
Yes. Let me see here. I thought maybe I had some. So my email
wonderful.
is here. Yep. So email would be the best way to contact me. There might also be a way within our Identify platform that you could message me if you want to. But email would be the best going forward. And I'm more than happy to, share more specific information about what we've been doing. We are always trying to make sure that we submit our project for publication, to try to share that with, the antibiotic stewardship community. So let me know how I can help you.
Wonderful. Thank you so much, Lindsey.
Thank you.
Again, if any attendees have any questions, feel free to reach out to Lindsey at her email listed on the screen. For all attendees also, for the next session, I believe it starts right after this at 2:30 or maybe even 2:35. It might be staggered. But feel free to stick around, use the chat box, or if you'd like to move to your next session, feel free. Thank you so much again, Lindsey.
Thank you.